So what we're discussing today, and I gather that we have dinner after this, so we'll just go very fast. And a very common condition, managing upper GI bleeding, how do we take the right decision? So upper GI bleed is an emergency. When we see blood, all doctors, what we first think is, but what if I make the wrong decision? The patient is bleeding, so time is important, and we need to know what to do. So we'll begin with our clipboard case. This is a 64-year-old retired physician, an amateur tennis player, no cigarette, no alcohol, had a transient ischemic attack 2 years ago, recently on naproxen twice daily for tennis elbow. He takes baby aspirin and clopidogrel, but no other medications, develops acute epigastric discomfort and melena the night following a tennis game. So what is upper GI bleed? Remember, it's a common medical emergency, and peptic ulcer is the single most common cause. 80 to 90% are actually non-vericial, and more than 70% of these cases are for people who are more than 60 years of age. The annual incidence seems to be coming down, but this is still relevant because the mortality rates have not changed. And we don't keep the records of how much the cost is, but in the US, it is more than $2 billion US. So that is the importance of upper GI bleed. How do they present? They can be hematemesis, they can be melena, as our patient had. It could be hematochezia, or they can present just with symptoms of iron deficiency anemia and sometimes hypovolemic shock. So our case, the first initial management issues, why would this physician who was otherwise doing well suddenly have that? Are there any risk factors? Well, yes, he had. His age was on the side of developing ulcer bleed. He was using naproxen, he was using aspirin, and he was using clopidogrel. So that gives us the first clue as to what we should think about. And issue number 2, how to assess who would be discharged or who would be admitted. Now he comes with melena in the evening at 8. Should we admit the patient? Should we send him home? That's another thing. So here we need an endoscopy. We need to see the clinical picture and then decide. Just to put it down in points, if you find that the patient has no shock, there's no high-risk stigmata seen on endoscopy, age is less than 60, hemoglobin more than 9, platelet count normal, he has a able family, that's important in India, who can support him, bring him back if needed. That is the case, you can actually send back to the hospital. So approach to management, first is initial assessment, resuscitation, then take a detailed history because that gives us the clue. Then we localize. Do an endoscopy, find out from where the bleeding is coming, and then, of course, the treatment plan. Other investigations? Yes, there are others. And these are case dependent. You do them if it is needed. You can do a nasogastric lavage if you don't have an endoscopy set up immediately to get an idea of how much blood, what else is happening. You can sometimes need an angiography when you can't find a cause on a routine endoscopy. But at the beginning, it's endoscopy which you need to remember. Initial resuscitation and stabilization may need blood transfusion, but remember, you need blood transfusion if the hemoglobin is less than 8. For more than that, watch for the amount of bleed and then take a call. So for our case, naproxen, aspirin, clopidogrel are stopped. Patient is admitted to the hospital. He's kept nil orally. IV PPI is started. Hemoglobin drops to 10 gram, meaning thereby he's still losing blood, and melena continues for 2 days. So what are the causes of bleed? What I just said, 80% is non-variceal bleeding. And it's only 20% that is variceal bleeding. And if you see in our hospital, we tried to calculate how things are. We find, yes, it is true, 80% is upper GI, peptic ulcers, gastric erosions, the others, Mallory-Weiss, Delafoy lesions, but again, the whole thing, variceal bleeding is just 20%. Causes in India, similar reflection as what we have seen. For our patient, the patient was hypotensive. Emergency endoscopy actually showed a clot in the antrum. The hemoglobin dropped by 2, down to 11. Even after blood transfusion, H. pylori was negative. So what do we do for managing non-variceal bleeding? There are 3 steps. One is drugs. Number 2 is, does the patient need endoscopic management? And finally, a few may really need surgery. So this is what you need to counsel your patient about. You can tell the attendants that these are the steps that we are going to follow. Now, what are the drugs that you can use? Vasopressin, somatostatin have been used, but actually not of much benefit. Do not waste your time on that. Antifibrinolytic story is the same. H2 receptor antagonists unlikely to provide necessary pH increase to stop a bleed, and so we have only the proton pump inhibitors. What does the proton pump inhibitors do? They increase the target pH. So if it is more than 6, that is when you can control the bleed. Less than that will not work. And there is no tolerance, so PPI is a mainstay of therapy. How does it work? We know this, but this is shown in a nice cartoon format because you can see that the PPI is actually reducing or increasing the pH of the stomach. And how does that help? The low pH converts pepsinogen to pepsin, which all help in dissolving the fibrin, and here all that is blocked. So we need to use PPIs because PPIs matter. They increase the pH and prevent clot dissolution. So remember, endoscopy is the pillar. You do endoscopy and you see where the blood is coming because that gives you confidence. But pre-endoscopy, resuscitate, give IV PPI. And post-endoscopy, again, give that PPI because it will decrease the rate of rebleed, decrease the rate of or need of future surgery. So this is how the patient will come. So pre-endoscopy, give high-dose PPI. You might be in a rural center where you don't have an endoscope. But what you should do is, whenever there is a bleed, give a high dose of PPI because preemptive use of IV PPI before an endoscopy can actually downgrade the ulcer, can actually improve future need for surgery and hospitalization. So pre-endoscopy PPIs have been shown to work. As you can see here, active bleeders are less in the people who have been treated with PPIs even before endoscopy. A patient can take it when he calls you up from his home that I've had this bleed. You can ask the patient, you take a PPI and rush to the hospital. So that also may help. So as you can see here, active bleeders are less in those who have taken omeprazole, and clean base ulcers are actually more in those who have taken omeprazole, meaning thereby PPI does work. During the procedure, during endoscopy, when you are doing a therapy, you're using epinephrine, using a heater probe, additionally give an infusion of PPI. What happens is adjuvant PPI improves outcome. So remember, pre-PPI, adjuvant PPI, and then post-endoscopy PPIs. As you can see the results, we are not going into the details of the studies in a pre-dinner symposium on Saturday, but IV PPI reduces rebleeding after endotherapy, endoscopic retreatment, and transfusion. So this is the general consensus which I just mentioned. But the question comes, which PPI? And which form and dosage? We have people coming and telling us about different PPIs every day. So which do you choose? That's the second decision making that you have to take, because you want the best for your patient. And this is like all the lists that you have and various trials, varying results. You really don't know what to do. So IV PPIs followed by infusion helps. What we have seen is there is a subtle difference between the different PPIs, and we conducted this study at our institute, and what we found was that there is that first few hours. What we find is that rabeprazole actually given intravenous, the pH rises fastest. So if you have to stop a bleed and you need the pH to go up to 6, the fastest will be with rabeprazole. To stop an immediate bleed, therefore, an IV rabeprazole may be a better choice. Again, we studied whether we can give it intermittent, because we have rural areas. We have people who do not have an infusion set. So even a local center can give IV PPI 6 hourly, and as you can see here, we did give 6 hourly and found in the lower graph, if you see here, we find that the pH is maintained above 6, and the red lines are the infusion. So you can give 6 hourly. If you don't have an infusion set, you can give IV PPI 6 hourly. Oral PPIs. Can we give oral PPIs? What if there is non-availability of an IV PPI? Getting an access is difficult. The patient is in shock. Even through the Ryle's tube, if you want, you can give, because Asians, they respond well to PPIs. And as you can see here, we can use buffered esomeprazole. So here the coating is not there. It's a buffer coating which acts immediately. So we can use oral as well. Then we come to endoscopic management. Now these are the different types of ulcers that you might see. If you see a spurter, if you see a deep ulcer with a visible vessel, you see an adherent clot, you know that below 2, you don't need endoscopic therapy. But the above are the ones in which you can help with endoscopic therapy. So you can classify it, but what you basically need to see is high risk. If there is a spurting, active bleeding happening, it's oozing, there is a sign of a recent hemorrhage, there is a clot there, that is when you need the gastroenterologist to go in and mechanically stop the bleed. Give the PPI, bring to the gastroenterologist, or if you are a gastroenterologist, wake up even at 2 a.m. in the night. If you see a spurter, ask your resident to call you. So what are the endoscopic therapeutic options? There is mechanical, there is injection, and there is thermal. You can use a heater probe and actually coagulate that area, stopping the bleed. So you see here, if you see this, so this is an emergency. Wash the area well during endoscopy, and what you're doing is injecting. And the result is the bleeding stops. So this is what you need to do. You can use thermal coagulation. As you can see, there is the gold probe, there is the heater probe. All will stop it. So there are the standard techniques now, and the question is, which should we use if it is needed? You can actually, it has been seen that you can use both. You can use a combination therapy rather than one alone when you see a bleed, because a bleed is an emergency and you must use all your instruments, all your arms, weapons to control the bleed. So combination hemostasis is actually better. The other is you can put a clip. Again, this is one in which you're bound to feel, oh my goodness, what is happening? But you put a clip, the bleed stops. And that's instant relief for the patient. So you can see how we can, for a bleed like this, you can use multiple clips and then stop the bleeding. Then there, as you can see here on the left side, there is gastric antral vascular ectasia, or GAVE as we call it. You can just use what we call APC, or organ plasma coagulation. Now what if there is an adherent clot? Do we leave it like that? Well, it's not bleeding, there's just a clot. No, don't do that. Because internally there is something, the clot will move, and then a torrential bleed will start. So it is better to cold snare the clot, expose the underlying lesion, see what is there, and take management decisions accordingly. Newer things are coming in. Now there is a hemo spray for human use. It still doesn't have a name. It is TC325. But this may change it. So these are the first videos that we actually got from Hong Kong, because that is the group which is using it. So if there is a bleed, there is a spray that you can use. You just see. This is the spray which is driven by that canister, and the bleeding can stop. So these are innovations which are simple to use and will be entering the market soon. Our patient is doing well, but he keeps on asking what next, and I thought it's important to tell a few words about GI bleeding in cardiac patients. We should remember elderly cardiac patients are the most vulnerable because of their age, their high comorbidity, there is polypharmacy. Most of the times there are numerous drugs, and there is pre-existent mucosal defects, and the bleed can happen. In such a cases, how should we help the patient? Use the lowest dose that can be for cardiac benefit. No additional cardioprotective benefit of ASA beyond 81, but increases the risk of GI bleed. Eradicate H. pylori. Complex antithrombotic therapy should be used only when benefits are likely to outweigh the risks. Use PPI for gastroprotection, and PPIs have been shown that at least a 66% reduction in upper GI bleed when you're giving dual antiplatelet agents. So prevention of recurrent bleeding ulcer, if it is H. pylori, treat for H. pylori, NSAID, stop NSAID, low dose aspirin. If there is a bleed, primary cardiovascular, do not resume the aspirin. However, if it is a secondary prevention, resume aspirin soon after hemostasis, 1 to 7 days, and start a PPI with it. If it's idiopathic, you don't know why the bleeding happened, keep the patient on maintenance PPI. Acute variceal bleed, we'll not get into variceal bleed today because of time constraints, and we've just finished, our patient is doing well. But a few basics. First bleed, remember 1/3 will die. 1/3 will rebleed, and survival more than 1 year is only 1/3. So though the incidence of variceal bleed is low, it is important. So management, we have pharmacological management, we have endoscopic management, and we have surgical management. As you can see here, these are big varices, and we can just suck it in, tie a band such that it does not bleed. So even during bleeding, you can actually do just the same, and that will prevent further bleed. If you cannot see, you cannot identify what area to band, if there is a lot of blood, you can go for sclerotherapy and then stop the bleeding temporarily. Later on, come back, relook, and do the banding. For gastric varices, you can use glue. So you can, if there is a bleed, use glue and seal the varix, preventing further bleed. And these are life-saving things which are done easily. You don't need an OT, you don't need sophisticated instruments, you just need the knowledge, the identification, and you can save lives. Is there a place for surgery? Yes, there is. If it is a severe life-threatening hemorrhage, not responding to all these therapies, if there is a perforation, obstruction, if there is malignancy, if there are recurrent hospitalizations or rebleed, we can actually need surgery. For gastric ulcer, there are numerous options. For duodenal ulcer, there are numerous surgical options. For varices, there are shunt operations, including TIPS. So radiology, surgical, gastroenterology, physician, all are important. For the managing of upper GI bleed, that is what you need. As you can see here, I've put an algorithm if it's an ulcer, active bleeding, IV PPI plus endoscopy, flat pigmented, no IV PPI or endoscopy, you can just admit. Clean base, you need not admit. Esophageal varices, we just discussed. If it's a malarivice tear with active bleeding, no endoscopy, active bleeding, endoscopy, no active bleeding, no endoscopy, only PPI and discharge. So this is a basic algorithm that you should follow, and your decision making will not suffer, because decision making in this is important. And as this is a platform for innovation, the search is on. Maybe one day we'll have a drug and which will say that have this for the next 43 years, no side effects, no bleed, you'll be fine. Or this is a video we have from our institute which tells us this is where technology will take us, maybe one day.
In between, there'll be a month of explosive action played against the backdrop of some of Germany's most exciting cities.
Here is a physician watching his favorite football match.
Both managers were on the edge of their seats for this heated encounter with Argentina.
On his TV screen, emergency message.
When the Germans were awarded a penalty, Brings made up his earlier miss with his measured finish. In response, the Argentines piled forward. Sorry was upended. Brianna's got an erratic action side with the play well. Brazilian ball Schalke striker poses a real threat in front of goal. The German defence stood resolute. Hold on, morale boosting. However, Crespo's world-class finish in the 81st minute ensured that honours finished even.
Patient goes to sleep.
Playing well, Brazilian-born Schalke striker poses a real threat in front of goal.
And the physician watches the last famous goal. So technology, what is fiction now, will one day be true. And if you want to know more about newest and the latest in technology, I cordially invite you all to Endo 2017 in February 2017 at Hyderabad.